if you broke a bone, you wouldn't just ignore it and hope it heals.
No, of course not. You go to a doctor.
Right. And you definitely wouldn't just quietly put up with the agony every single time you tried to walk.
Obvious.
But the craziest part is that right now, millions of women are doing exactly that with a physical condition that literally alters their anatomy.
Yeah, they really are.
It makes intimacy agonizing, and it causes this constant daily pain, and they are just doing it entirely in silence.
Well, it really is one of the most pervasive yet completely hidden issues in women's health today.
Yeah, because nobody talks about it.
Exactly.
Yeah.
We have this, this cultural expectation that menopause is just a temporary phase.
I mean, just hot flashes and mood swings.
Right, hot flashes that you just grit your teeth and get through.
Yeah.
But what we are talking about today is a progressive, chronic structural change. It does not go away on its own.
So for you listening right now, welcome to this deep dive. Our mission today is to tackle a highly common but incredibly isolating question head on.
And it's an important one.
It really is. The question is, what can you actually do to treat painful intercourse and vaginal dryness?
Because there are real answers.
There are. And to get you those answers, we have pulled together a massive stack of sources. We are going through clinical guidelines from NICE, which is the National Institute for Health and Care Excellence.
Right, the gold standard in the UK.
Yep, along with the NHS, the British Menopause Society, the American Urological Association, and even some specialized physical therapy clinics.
And we should probably start by, giving this condition its actual medical name.
Oh, good idea.
Because the medical community now refers to it as genitourinary syndrome of menopause, or GSM.
GSM, okay.
Right. And over the course of this deep dive, we're going to map out an exact evidence-based progression of treatments for it.
So we're going from, the easiest options up to the big ones.
Exactly. We'll explore the underlying mechanisms of why this happens, walk through the first-line pharmacy solutions, and dive into the true medical gold standards.
And crucially, we are going to expose a few heavily marketed, very expensive procedures that the medical guidelines warn you should absolutely avoid.
Yes, that part is so important.
But let's start with the root cause. Because if we want to fix the pain and the dryness, we have to understand what is physically changing in the body.
Right. You can't treat what you don't understand.
And based on the sources, it's not just a switch flipping off where someone suddenly loses their libido. It is a fundamental anatomical shift.
It is a profound structural change, yeah. And the primary driver here is declining estrogen levels.
Which happens in menopause.
Right. Usually this happens naturally as you transition into menopause. But it can also be triggered abruptly by certain medical treatments, like therapies for breast cancer.
Oh, wow.
Yeah. Now, estrogen is essentially the hormone that keeps the tissues of the vagina and vulva healthy, thick, and elastic.
Okay, so it's like the maintenance worker for that area.
Exactly. It signals the cells to hold on to moisture and maintain a robust blood supply.
Wait, so when estrogen drops, the lining actually physically changes?
Dramatically. I mean, the medical term for the surface layer of the tissue is the epithelium.
The epithelium, okay.
Right. And when estrogen is removed from the equation, that epithelium becomes much, much thinner. It loses its elasticity completely.
So it's literally shrinking.
Well, the network of blood vessels shrinks, which means the blood flow to the entire genital region drops significantly.
That sounds awful.
It is. Even the natural pH of the vagina changes. It shifts from a healthy, protective, acidic environment to a more alkaline one.
So it's not just that things feel a little dry then.
No, not at all.
Because the sources describe an entire cluster of symptoms, like persistent itching, chronic burning, micro tears in the tissue.
Yes, actual physical tears.
Which actually leads to spotting after sex, and dyspareunia, which is the medical term for painful intercourse.
Dyspareunia.
It makes me think of like a kitchen sponge.
Okay, I like that analogy.
Like if you leave a damp sponge out on the counter for a few days, it dries out.
It gets completely hard.
Exactly. And when it's completely dry, it's brittle, it's scratchy, and if you try to pull or stretch it, it just rips.
Yep, it tears apart.
But when it's hydrated, it's bouncy and resilient.
That sponge analogy is actually a great way to visualize the mechanical properties of the tissue.
Right, because it's about the physical resilience.
Exactly. When the epithelium thins out and loses its moisture, the friction of intercourse causes actual micro-traumas.
You are pulling on a brittle sponge.
Yes, exactly. But looking at the broader clinical picture, it's vital to understand that it's not just about the vagina.
Oh.
This is the whole reason the medical community changed the name to genitourinary syndrome of menopause.
Oh, right, because it affects the urinary tract, too.
Exactly. Estrogen receptors aren't only located in the vagina.
Where else are they?
They are clustered everywhere in the pelvic region. They line the urethra, which is the tube you urinate from, and they line the base of the bladder.
Oh, wow. I had no idea.
Yeah, so this biological desertification process directly weakens those tissues as well.
Which causes what?
It leads to sudden urinary urgency, leaking, and a massive spike in recurrent urinary tract infections.
That makes so much sense. Okay, so if the tissue is behaving like a dried out, fragile sponge, I think the most immediate natural instinct for anyone is to just grab something to make it wet.
Right, just add water.
Yeah. Run to the pharmacy, buy a tube of something, and fix the friction. But looking through the WHO and NHS guidelines, they are intense about what you should actually be putting on your body.
They have to be,
Really? Why?
because using the wrong product at the wrong time is the main reason people get frustrated and assume over-the-counter options are useless.
Okay, so what are they doing wrong?
Well, the first thing you have to understand is the functional difference between a moisturizer and a lubricant.
Break that down for me, because I always assume those were just two words for the exact same thing.
A lot of people do, but they serve completely different biological purposes. Lubricants are designed to be used strictly during sexual activity. Their only job is to sit on the surface of the tissue and temporarily reduce friction.
So they just stay on top.
Right. They do not change the underlying cellular health of the tissue at all.
And moisturizers.
Moisturizers, on the other hand, are meant to be used regularly, usually like several times a week,
Even if you aren't having sex.
totally independent of whether you're having sex or not.
So a moisturizer is actually trying to repair the tissue.
Yes, a good vaginal moisturizer is formulated to be absorbed into the epithelium.
Okay, that makes sense.
It binds to the cells. It mimics natural vaginal secretions to restore the fluid content, and it actively lowers the pH back to a healthier acidic level to ward off infections.
I see. So a lubricant is kind of like using a slick shaving cream right when you need to shave so the razor doesn't drag.
That's a good way to put it.
But a moisturizer is like your daily face cream that actually repairs your skin barrier over time.
Exactly.
Like you wouldn't use shaving cream as your daily lotion.
No, you wouldn't.
And your daily lotion wouldn't really protect you from a razor blade.
That is a perfect way to look at it. But this is where the guidelines from the World Health Organization issue a really urgent warning.
Uh-oh. What's the warning?
You cannot just grab any random lubricant or moisturizer off the shelf. You have to look at the osmolality of the product.
Wait, osmolality?
Yes, osmolality.
That sounds like a concept from like high school chemistry. What does that actually mean for my tissue when I apply a product?
Well, osmolality is simply the concentration of particles,
Like what kind of particles?
like sugars, salts, or synthetic compounds in a fluid. The WHO recommends that personal lubricants must have an osmolality of less than 1,200 milliosmoles per kilogram.
Okay, and if it's higher than that? Because I'm guessing a lot of commercial drugstore brands are.
Oh, many popular drugstore brands are much, much higher.
So what happens?
Think of what happens if you take a fresh, plump strawberry and cover it in dry sugar.
Okay, yeah. It gets all syrupy.
Right. The high concentration of sugar on the outside actually pulls the water out of the strawberry cells to try and balance things out. The strawberry shrivels up.
Oh, wow. So if I put a highly concentrated, high osmolality lubricant on my already dry vaginal tissue,
It biologically pulls the remaining water out of your cells.
it dehydrates me more.
Yes, it dehydrates the tissue even further.
That is insane.
And that forced dehydration causes something called cytotoxicity, which literally means cell death.
Cell death from a lubricant.
Yes. It destroys the outer layers of the cells, leading to contact dermatitis, severe irritation, and a complete breakdown of the mucosal barrier.
So you buy a product to fix your dryness, and it actively damages the tissue on a cellular level.
Exactly.
That is horrifying.
It is, which is why checking the ingredients is so crucial.
What about people who just skip the pharmacy altogether and go for natural oils, like coconut oil or olive oil?
Well, plant-based oils generally have a low osmolality, so they
Yeah.
won't cause that specific cellular dehydration.
So they're safe.
Well, they come with a major mechanical catch.
Oh, right. Latex.
Yes. Oil degrades latex almost instantly. If you rely on latex condoms for contraception or STI protection, or if you use certain medical dilators or sex toys, oils will literally melt and destroy them.
That's a disaster waiting to happen.
Totally. Our sources also strongly emphasize avoiding any products that contain propylene glycol, parabens, artificial flavors, or warming agents.
Let me guess. The warming agents are basically just chemical irritants.
Spot on. They cause a minor inflammatory response to create that so-called warming sensation.
Which sounds terrible for injured tissue.
Right. If your tissue is already thinned out, brittle, and covered in micro tears, inducing chemical inflammation is the absolute last thing you want to do.
Okay, so let's say someone follows the protocol perfectly.
Okay.
They find a high-quality, water-based, low osmolality lubricant for sex.
Right.
They use a dedicated moisturizer 3 times a week. But what if the surface level stuff just isn't enough?
That happens a lot.
Because if the sponge is truly deteriorating on a structural level, lotion isn't going to rebuild it right.
And that is the reality for many women. If the symptoms persist, you have to replace the signaling hormone that the body stopped making.
You have to bring back the estrogen.
Yes, you need to tell the tissue to rebuild itself. That brings us to the medical gold standard for GSM, which is localized vaginal estrogen.
Whoa. Okay, stop right there.
I know, yeah.
Because I know for a fact that the moment you say estrogen therapy, alarm bells go off for a lot of people listening.
Oh, absolutely.
People immediately think about those massive, terrifying headlines from, 20 years ago? They worry about systemic risks.
Blood clots, strokes, breast cancer.
Exactly. Everything associated with traditional hormone replacement therapy, or HRT pills.
The fear is totally understandable given the history of HRT media coverage, but it is fundamentally based on a misunderstanding of the mechanisms of local estrogen.
Local versus systemic.
Right. The clinical guidelines from NICE, the British Menopause Society, and the American Urological Association all go out of their way to reassure patients with very precise data.
What does the data say?
Well, local vaginal estrogen, which comes in like tiny tablets you insert or creams or soft ring, is a completely different ballgame than a systemic HRT pill or a skin patch.
How so? Because, estrogen is estrogen, right? Does it not just enter the bloodstream anyway?
No, it acts directly on the vaginal and vulvar tissue, and the systemic absorption is practically non-existent.
Wait, really? How does it not get into the blood?
The reason is that the local estrogen receptors in that thinned-out tissue are essentially starving.
Okay.
So when you introduce a microscopic dose of estrogen directly to the vagina, those local receptors gobble it all up immediately to rebuild the local cells.
Oh, I see.
There is virtually nothing left over to spill into the general bloodstream.
Do the sources give a sense of just how small that dose is?
They do, and it's kind of mind-blowing.
Let's hear it.
If you use a standard 10 microgram vaginal tablet, like Vagifem or Gina, your total absorption of estradiol into your bloodstream over an entire year is roughly 1.14 milligrams.
Annually.
Annually.
That is almost nothing.
It is so low that, unlike women who take systemic HRT pills, you do not even need to take an opposing hormone called progestogen to protect the lining of your uterus.
Because it just doesn't travel that far.
Exactly. The estrogen simply does not reach the uterus in any meaningful quantity. It just stays in the vaginal tissue, thickening that epithelium back up, restoring the blood flow, and reversing the atrophy.
Wow.
It's considered so remarkably safe that in the UK, you don't even need a prescription for certain brands anymore.
You can just buy it.
Yeah, women over 50 can just speak to a pharmacist and buy it over the counter.
That is a massive shift in accessibility. It takes away so much of the stigma, too.
It really does.
But I want to pause here because I can imagine someone listening right now who has done all of this.
Yeah.
Like, they tried the moisturizers, they got the local estrogen prescription, and the doctor says their tissue looks completely healthy again.
Visually, it's healed.
Right. But sex is still painful.
Yes.
That level of frustration must be incredibly isolating. What is going wrong in that scenario?
This is a critical point, and it brings us to the muscle connection.
The muscles.
Yeah, the guidelines outline a fascinating physiological loop that occurs when pain is left untreated for too long.
Like a habit.
Exactly. If you experience painful sex due to dryness over months or years, your brain learns to anticipate the pain.
Oh, so it builds a defense mechanism.
Exactly. Before penetration even happens, your brain sends a panic signal, and the muscles of your pelvic floor involuntarily clench and spasm to protect you.
Like flinching before you get hit.
Yes. And over time, this creates a condition called a hypertonic pelvic floor. The muscles become locked in a chronic state of tension.
So the estrogen might have successfully cured the dryness and thickened the tissue.
But the pain remains entirely because your muscles are cramping severely.
Wow. And this is where pelvic floor physical therapy comes in, which is heavily featured in our clinic sources.
Yes, it is a game changer.
But I really want to clarify this because when most people hear pelvic floor exercises, they immediately think they need to do Kegels.
Which would be the worst possible thing you could do.
Right. If your pelvic muscles are already clenched in a chronic spasm, doing Kegels to tighten them further is like, well, it's like doing bicep curls when you have a severe locked up cramp in your arm.
That's exactly what it's like. Pelvic PT for dyspareunia isn't about tightening at all. It's entirely about relaxing overactive muscles.
So what does the therapist actually do?
A specialized pelvic floor physical therapist will use manual therapy to release trigger points inside the pelvic muscles, much like a massage therapist releasing a knot in your shoulder.
Okay, that makes sense.
They will mobilize old scar tissue, perhaps from childbirth or a previous pelvic surgery, and they heavily utilize medical devices called vaginal dilators.
How do those work mechanically?
Dilators are smooth, graduated cylinders that come in increasing sizes. Under a therapist's guidance, you use them to gently, slowly stretch the tissue.
Okay.
But more importantly, they are a neurological tool.
Neurological, like retraining the brain?
Exactly. They help retrain your brain and your muscles to accept penetration without triggering that involuntary spasm. You are slowly desensitizing the area and breaking the pain loop.
Now, what about women who simply cannot use local estrogen?
Like who?
Say a breast cancer survivor who is on specific estrogen-blocking medications, and her oncologist says absolutely no estrogen, not even local.
Right. That's a very real scenario.
Are there alternative medical treatments that actually repair the tissue for them?
Yes, the guidelines highlight 2 innovative next-generation prescription medications that do not involve applying direct estrogen.
What's the first one?
The first is prasterone, which often goes by the brand name Intercourse. This is a nightly vaginal insert made of DHEA.
Wait, DHEA, isn't that just a precursor hormone?
It is.
How does that help rebuild the vaginal lining if it's not actually estrogen?
That's the genius of it. You insert it, and the local vaginal cells absorb the DHEA. Once it's inside the cell's own internal machinery converts that DHEA into whatever it needs locally,
Which is what?
both estrogen and testosterone.
Testosterone. Wait, why is testosterone important for vaginal health? I thought that was just a male hormone.
We culturally think of testosterone as a male hormone, but women rely on it too.
Really? For what?
In the vagina, testosterone plays a vital role in maintaining the strength of the connective tissue, the elasticity, and the health of the local nerve endings.
Oh, wow.
Yeah, and prasterone delivers that dual benefit strictly on a local cellular level without raising hormone levels in your blood.
That is fascinating. And what's the second medication?
The second is osbemifene, or Sensio. This one is unique because it's a daily oral pill.
A pill, but we just talked about how local is better.
Well, the mechanism here relies on a class of drugs called SERMs, selective estrogen receptor modulators.
Selective. How does a pill circulating in your entire bloodstream know where it is and how to act?
Think of the drug molecule as a very specific master key, and your body's estrogen receptors as locks.
Okay, I'm following.
When osbemifene encounters the locks in the vaginal tissue, it fits perfectly, turns the receptor on, and acts exactly like estrogen to thicken the tissue and lower the pH.
Just like regular estrogen.
Right. But when that exact same molecule travels up to the breast tissue, the lock is slightly different.
So it doesn't fit.
The key fits in, but it can't turn. It jams the lock, blocking any real estrogen from getting in.
Oh, I see. So it actively thickens and heals the vagina while acting as an antagonist to block estrogen effects in the breast.
Exactly.
That is an incredible workaround for people who want the convenience of a pill but need to protect their breast tissue.
It is an incredibly elegant pharmacological solution to a really complex problem.
All right, so looking at all of this, we have highly effective, proven therapies. We have the science of low osmolality moisturizers, the gold standard of local estrogen, pelvic PT to break the muscle spasm loop, and SERMs.
A lot of great options.
But let's be real, it is human nature to want a quick fix.
Always.
Because rebuilding cellular tissue and retraining muscles takes weeks, sometimes months.
It requires patience.
Right. So I can see why someone would get frustrated and look for a fast track. Which brings us to the private clinics heavily marketing energy-based devices.
Yes.
Specifically, transvaginal lasers.
Devices using fractional CO2 or erbium-YIG lasers. And this is where we have to issue a severe clinical warning based on the medical guidelines.
What exactly is the marketing claim here? Because I mean, lasering your vagina sounds intensely aggressive.
It does. The premise is actually borrowed from facial dermatology.
Like for wrinkles.
Exactly. The idea is to insert a laser and cause controlled, microscopic thermal burns to the vaginal walls.
That sounds painful.
Well, in theory, the body's immune system will rush to heal those tiny burns by stimulating a massive production of new collagen, magically rejuvenating the tissue in just a few expensive 10-minute sessions.
But both NICE and the American Urological Association state explicitly that long-term safety and efficacy data for these lasers in treating GSM are severely lacking.
They classify them as experimental.
And reading through the NICE interventional procedure overview, I mean, the documented adverse events are harrowing.
Because the theory of how the tissue heals is completely flawed in this specific population.
Let's talk about why. Because the case studies recount women who went into a clinic with just mild vaginal dryness, they got the laser treatments, and ended up with severe levator muscle spasms.
Yes.
In some cases, the laser actually created fibrous bands of scar tissue mid-vagina, effectively creating a stricture that partially obstructed the vaginal canal.
It's devastating.
Why does the laser do that here when it works fine on someone's face?
Because you are dealing with menopausal tissue.
Okay, so the tissue acts differently.
Very differently. When you cause a microscopic third-degree burn on a healthy face, the skin has plenty of estrogen and collagen reserves to bounce back and heal smoothly.
Right. It has the building blocks.
Exactly. But postmenopausal vaginal tissue is already starved of estrogen.
Yeah.
It lacks the biological building blocks required to heal a thermal burn properly.
So what does the body do?
Instead of generating bouncy, resilient new tissue, the body panics and just throws down rigid, hard scar tissue to close the wound.
And the pain profile for these women worsened dramatically.
Oh, yes.
Women reported that intercourse went from mildly uncomfortable before the laser to severely painful upon any penile insertion.
Completely counterproductive.
Some of these patients required extensive medical intervention just to recover from this so-called rejuvenation procedure.
Like off-label use of intravaginal Valium?
Yeah, just to try and stop the severe muscle spasms
Yeah.
and agonizing dilator regimens, just to try and stretch that new scar tissue back out.
It is a stark reminder of a fundamental medical principle. This thinned, fragile tissue needs gentle, hormonal, or cellular rehabilitation.
It needs care, not trauma.
Exactly. Intentionally burning it to force a healing response when the body lacks the physiological tools to heal carries significant irreversible risks compared to simply supplying safe local hormones.
We have covered a massive amount of ground today, and I think the through line is incredibly empowering.
I agree.
If you are dealing with painful sex or dryness, you have an arsenal of safe tools. Start by auditing your nightstand.
Check those ingredients.
Yes. Ditch the high osmolality lubricants that are dehydrating your cells. Find a quality moisturizer and use it regularly.
And if that isn't enough, do not let outdated fears keep you from the gold standard.
Right. Local vaginal estrogen is microscopic in dose. Virtually zero makes it to your bloodstream, and it actually addresses the root cause by feeding those starving cells.
And if you repair the tissue but the pain is still there, remember the muscle connection.
Don't do Kegels.
Don't do Kegels. Seek out a pelvic floor physical therapist to help break the pain spasm loop in your brain and relax those hypertonic muscles.
Or, ask your doctor about the cellular brilliance of prasterone and ospemophene.
Just steer clear of unproven laser therapies promising a shortcut.
Most importantly, you do not have to accept this pain as a normal part of aging. Treatment works.
It really does. And I want to leave you with one final thought to mull over.
Let's hear it.
We have focused almost entirely on painful intercourse and dryness today. But remember earlier when we established that those estrogen receptors don't just line the vagina.
Right, they line the bladder and urethra too.
Exactly. So here's something to explore on your own or bring up at your next doctor's appointment. Could treating your localized vaginal dryness with a simple, safe estrogen cream actually be the hidden secret to stopping those mysterious recurrent urinary tract infections and bladder leaks that so many women are told they just have to live with?
Wow. It all comes back to the sponge. If you hydrate the sponge properly, the whole surrounding ecosystem thrives. Tend to the garden. Don't let the desert take over. Till next time.